What I'm going to do here is just talk to you a little bit about our company, some background on the magnitude of the disease that we're seeing these days. We have some fairly surprising statistics, and just a little about the program. And then Sally is going to take over and talk to you a little bit about some of the results we've been seeing. You know, it's still early days. We're still in the process of implementing our program, but even in these early times, I think we have some very exciting results we'd like to talk to you about. Most of you probably know us as DCC. You'll see Rena Logic here. We are actually in the process of rebranding. We began our life pretty much as a dialysis cost containment company, and although that continues to be a very big part of our service offering, we realized that there is a huge opportunity for broader renal risk management. So over the last 3 to 4 years, we've really been expanding into taking over that full spectrum of renal risk management for our clients. And so therefore, we are rebranding to Renalogic. We're excited. We're launching a new website. And so please check it out if you get a chance. We are very proud of the people that support us in our program, including our Chief Medical Officer, who's a nephrologist, our Director of Medical Management, who is a nurse that has decades of experience with chronic kidney disease management, and our nurse coaches, who are all registered nurses. So we bring a lot to the table as far as expertise and capabilities with this program. I said I had some startling statistics, and every time I look at these slides, it surprises me more because the problem, as I'm sure you're all aware, is actually growing. The National Kidney Foundation statistics as of, I think, 2014 now indicates that over their lifetime, 1 in 9 people in the United States will develop chronic kidney disease. And as you all know, left unchecked, that tends to deteriorate into dialysis. In addition, if you look at comorbidities, 1 in 5 people that have hypertension will develop the disease, and 1 in 3 people, so 1/3 of all people with type 2 diabetes will develop chronic kidney disease. And as employer groups, you all know that this is catastrophic, not only from a healthcare perspective, but from a cost perspective. So that is one of the things that we really want to do, is try to address this, this disease and this condition before it deteriorates into full-blown end-stage renal disease and dialysis. One of the things that we wrestle with as we're working through this, this condition is that it is vastly underreported from a cost perspective, and that goes along with the fact, as many of you probably know, that so often people that have chronic kidney disease do not know it. It is recognized they have comorbidities such as hypertension, diabetes, obesity, you know, all the things that go along with it, but often the kidney disease is not recognized until you're in the very late stages of the disease and, you know, heading towards dialysis. So one of the things we try to do is sort of help tease out the cost of the underlying disease along with the comorbid conditions so that we can actually look at what type of overall savings can be achieved. Another really interesting statistic is the way that we actually deliver renal replacement therapy in this country. In most of the developed world, you will find that by far and away the highest percentage of people are utilizing home modalities. But as you will see from this slide, it's the absolute reverse in our country. The vast majority of people, especially if they are undiagnosed until the end up in an emergency room with an urgent start. The average cost of that whole process can be over $100,000. They have a catheter placement, they end up in a center, and once they're in a center, it's very unlikely that they will go and utilize any other method. And the problem with this is not only that it is the most expensive, but it is also the least healthy. Home modalities are far healthier for patients, and they also are far better from a success as far as transplant goes. Transplant is another thing that we really like to educate members on. We don't do transplants ourselves, obviously, but we do educate our members on the advantage of early transplant and obviously familiar donor transplant if at all possible, because the sooner a patient transplants, the more likely it will be to be successful. Another really interesting statistic on this slide is that 60% of the people who start dialysis have never seen a nephrologist. So again, that tells you a lot about how unknown this disease is by many of the people that have it. So how do we address this? So what we have done over the years is developed an ability to actually do, it all begins really with predictive modeling and data analysis. We've developed a proprietary algorithm. What that does is it takes claims data, we usually take 12 to 24 months, and do an initial risk analysis, and we can actually stratify an employer group and look at the different, what we call risk pools in that employer group. And the way that we look at this is at the very top, of course, is in this slide, you'll see CKD. It's what we call our program core, and Sally's going to talk a little more about this. These are the people that have either a CKD or end-stage renal disease diagnosis, or they have a procedure associated with it, so like an access placement. So these people, again, are people that are a little easier to find because, you know, it is in the claims data. Our next category down, however, is what we call our high-risk silent group. And these are people who are highly likely to have chronic kidney disease, probably stage 3 and above, but they have not been diagnosed. And in most cases, they are not aware that they have it. And this is kind of the, this is the emerging risk group. These are the people who, left unchecked, could easily end up in dialysis in the next 6 to 12 months. And again, are typically unaware of the fact they have it. Our next group down is what we call our moderate risk group. And this is a group that's probably in the early stages of the disease, but again, really are unaware that they probably have the disease or what they can do about that disease. The reason we feel this group is important is they are the easiest ones to impact as far as halting the progression of the disease very early. These are not typically as expensive to the employer group, but if we intervene in time, we can keep them from becoming that expensive. Plus, we can also obviously keep them much healthier, which means that they are a much more productive employee. And then the last group, of course, is the group that does not trigger our algorithm. And these are the people that we look at as sort of a baseline. And so the key elements of our program, as was mentioned in the earlier presentation, is really, it's a very comprehensive approach. It's not just large case management or disease management. It's really a holistic approach to education, understanding, treating comorbidities with the goal of delaying or halting the progression into end-stage renal disease. This just gives you a snapshot in time. This data is a little bit old, but we took all of the Cypress data and we ran it, and this is kind of what the output looks like. So what we will do is when we take a group or a group of employers risk data, and this is sort of how we stratify it. So we can show each individual employer how many people are in the program core, how many people have triggered the high risk silent, and how many people are in moderate risk. So that's sort of the way we start if you're looking at the data analysis. And I know we've had a chance to work with several of the employer groups in this room where they've been able to see these types of results. So the next question is, what do we do from here? So it's great that we've identified all these people and that we can understand and stratify the risk. But the next question is, so how do we go about working with these members? And as the people that have worked with us are aware, it starts with engagement, and that's really a very holistic approach. And Sally's going to talk a little more about that. But working with you as the employer group and with the employees to try to make sure that we are identifying, educating, contacting, and selling the benefits of the program. We really, in addition to the chronic kidney disease, obviously we're managing the whole person. So we do help them with the comorbid conditions, compliance, education, all the things that are really important as far as that goes. Early intervention is key. The earlier we can get to people, the better chance we have of keeping them healthy and ultimately keeping them out of dialysis, which is a win-win for everyone. And I do want to point out that all of our program is really based on National Kidney Foundation guidelines, and so our outcomes are very much tied to the all of the data and the teachings that come out of the National Kidney Foundation. So with that, I'm going to turn it over to Sally. And as I said, it's been early days. Obviously, we're still in the process of implementing several of the groups, but we're very excited about some of the results that we have to share.
Thank you, Shelley. I'm really excited to be here. Sorry.
She's a foot taller than I am.
Yeah, just a little taller. I'm really excited to be here, primarily because this is a really good opportunity for us to share the preliminary results that we've had with the program for the 6 implemented plans that we have to date. It takes about 12 months or so for us to really see the results of the financial costs of the program, the results in the claims cost. So the preliminary results I'm going to be sharing are mostly about avoided costs that we've been able to identify to date. It takes 12 months primarily because you have to engage the member. That takes some time. You have to get the members, you have to do a chronic kidney disease assessment of that member. You have to get the members' medical records from their PCP or their nephrologist or their cardiologist or endocrinologist. And then you have to work with that member to set realistic goals for them, educate them about those goals, and get them on a path in order to make behavior changes. Because it's the behavior changes that really have the impact on your claims costs down the road. So we have had 4 to 5 months of really quality engagement with the 6 plans that we've implemented. We anticipate those 6 plans are just the beginning of many more to come from Cypress, and I'm hoping that the excitement of the results we have today will help educate you guys out in the audience to understand how good this program can be for your employees. So we have seen cost savings to date of $126,000 in avoided medical costs. We've seen a spared admission for an emergency catheter placement. We've seen a spared 1 month of avoided dialysis. We have seen 2 spared emergency room visits, and we've seen some savings due to spared medication costs. In the 6 plans for the participating members that we've worked with, there has been no emergency room or non-elective hospital admits for the participating members that we've worked with in the time that we've worked with them. And there has been no participating program members who have progressed to dialysis. And we have seen several members who are at a stage 4, stage 5 that we picked up. So we've been it's been very good that we've been able to make a difference with their kidney functions, as we get them to participate in the program. I want to share some quantifiable successes at the plan level. We look at this point in the progression of the preliminary results, we look at member engagement rates as one of our success factors, but we also really look at renal health and how that measurement of renal health has been impacted by the program, because that's really where the rubber meets the road and where the savings will happen through that delay of that member progressing on to dialysis. So we use a measure that the National Kidney Foundation uses. It's called the estimated glomerular filtration rate. Say that 10 times fast. But the eGFR is the rate that is used to measure kidney function, and it is not the only measure that the National Kidney Foundation uses to measure kidney function, but it is really the one that identifies how a member is progressing through the multiple stages of chronic kidney disease. A member who has a eGFR of greater than 90 has normal kidney functioning. A member who has an eGFR of less than 15 is fast approaching kidney failure and ESRD and dialysis. So we look at increases of 5 points on this eGFR as being a success rate. So if we see 5 points up from their last measurement of eGFR, that member has, in fact, made enough difference to actually make a difference in their complete health status. So with that said, I'm going to go through the different plans that we have engaged and what we've been able to accomplish to date. So for the first plan, we identified 77 members at risk of chronic kidney disease. We've accomplished an 82% engagement for the members contacted to date, and of those members, 6 members have had an average increase of 12.15% increase in their GFR since they started engaging with their nurse coach. Our second plan that we worked with had 44 members identified at risk of chronic kidney disease. With this plan, we had an 89% engagement rate for members that we were able to contact. We had 2 members who improved their renal function with an average of 6.5%. And unfortunately, we've seen 1 member who's had a 31% decline in renal function since we started working with her. And our nurses working very aggressively with this member to turn that around and halt that progression and not see her progress to end-stage renal. The third plan had 42 members identified at risk of chronic kidney disease. We achieved a 67% member engagement for those members we were able to contact. We had 1 member with an improvement in their renal function of 14% and 2 members who achieved a stable renal function. The fourth plan, we identified 47 members at risk of CKD. We achieved a 71% engagement for the members contacted. Our nurses continue to perform outreach and education and testing and have been able to stabilize 4 members' GFRs in the past 4 months. The fifth plan, we identified 36 members. We achieved an 87% engagement rate for the members contacted. 2 members had an average of 16% improved renal function, and we have 1 member in that plan with stabilized renal function. The sixth plan was a bit of a challenge. We identified 415 members. We had a 60% engagement for the members contacted to date, and we were asked to hold off on contacting new members of the group. So we really are only working with a small group of the originally identified members to date. But the data indicates that of those 415 members that were identified, there is a high number of members that we can help with this program, and we are looking forward to working with this plan to try and get an approval to start the re-engagement process with these members this coming year. This next slide shows the process of how the employer group engagement process happens. It's been refined over the course of the past 4 or 5 months, and that's largely because we adapted how we were going about the employer group engagement and member engagement to address some of the issues that we had with the implementation of the first 6 plans. These process steps we believe are critical. We work with Cypress hand in hand to develop these, and we believe that these process steps are critical to ensuring that an implementation of our program is successful for the plan and for the member. It starts with, as Shelley talked about, it starts with the at-risk member identification by the Rena Logic team, which we share those results with Cypress. Cypress will then outreach to the employer group and share their risk profile of their members. And if the plan is interested, then there will be a full-scale education of the HR folks and all the member support personnel within the plan so that they understand the program, that they can answer any questions that an employee may have, so that the employees feel confident when they ask about the program that this is in fact backed by their employer group and is a good thing for them to participate in. We would then create a member information campaign, which would be done by the employer group, and that member information campaign would be targeted to all potential employees who might be at risk of chronic kidney disease, or we would send it out to all plan members, depending on how the employer group wants to do that. Only then, once the members and the employer group really understands the education or understands the program and feels like this is the right thing, will we begin any outreach to members. And at that point, we do at-risk notification by the Rena Logic nurse coach through a letter as well as a follow-up phone call. That's when member engagement starts. If we are able to achieve contact with the member, as you can see, we do have fairly high success rates in getting the member engaged. And the other critical piece, or the last critical piece of this engagement process for the employer group, is really doing or providing ongoing support by the employer group to the program. But if we can do all these steps, it should enable a very successful implementation all around. So our lessons learned from the 6 implementations came up with these key factors to promote implementation success. As I said, the program education to all employer group HR and employee support resources, a collaboration between Cypress, the employer group, and Rena Logic to promote the program to the employees through payroll stuffers, company emails, mailings, however the company feels best, the employer group feels is the best way to reach out to your employees. Rena Logic needs assistance with accurate phone numbers and contact information. So many of the employees' phone numbers change. It's not always valid phone numbers that we get on the eligibility feed. And then continued support of the program to answer employees' questions from the company HR and employee support resources. So if we get these done, it will, you will see the cost savings because the program will be successful. My next set of slides is really highlighting the types of cost avoidance successes that we've had with our program to date and what our nurses can achieve. And I really want to thank Mary Erickson for calling out the successes that SAP has seen to date with our program. And basically what I have here is, it's a non-Cypress case study. It's for a pre-Medicare retiree, and I'm using this case study in order to demonstrate the length of time that our ability to delay the onset of ESRD can come about, and how much savings a plan can see from that if you can delay that member from going on to dialysis. So we had a stage 5 CKD member on the brink of dialysis with 12% kidney function. And remember, I said anything under 15% GFR is basically kidney failure. We took on that member, we started interventions and education and coaching, and we were able to improve that member's renal function and general health status. And we were able to keep that member off of dialysis 18 months and counting. The member is still dialysis free. His renal function has improved 47%, so that essentially he went from a stage 5 to a stage 3 chronic kidney disease through the nurse's interventions and the behavior changes that he made. So that saved the plan more than $540,000 in avoided dialysis costs. And we're still adding $35,000 a month as we move forward. So it's really impactful for this plan. My next one is actually it is Mary's case that she was referring to. We got this stage 4 CKD member who had low renal function. This member was being non-compliant. This member really was not working with her nephrologist at all. We did outreach as part of our normal outreaches. We not only outreach to the member, but we also outreach to the provider. So we sent a letter to this member's nephrologist, who in turn picked up the phone and called our nurse coach, our RN directly, and said, please help me with this member. This member's non-compliant. She needs to have an access placed. What can you do to help me get that access placed? She's missed 6 appointments. She's not taking her meds. She's just not working with us. Our nurse was able to engage the member, to get the member, as Mary said, to start losing some weight. The member was able to get on board with the fact that she wants to take care of herself and that she understands that an access placement is a much far superior type of outcome for her than to go into renal failure as an inpatient, have a catheter placed in her neck, and then she's just tied to outpatient dialysis for the rest of her life. So the nurse was able to coach her into getting an access placed. 6 months later, the member is still dialysis free, and her renal functions have improved slightly. With this, typically 6 months after an access is placed, an access requires 6 months to harden and mature. So once an access is placed, typically a nephrologist expects that member to go on dialysis at month 6. And so this member at month 6 is dialysis free. We're able to identify that we have avoided 1 month of dialysis to date, as well as we avoided an urgent start catheter, and therefore we saved the plan $119,000. So good result in just 4 months. My last case study is another Cypress member, and this member is one of the members who were identified in that moderate risk categories. So it was a member who had 2 comorbidities, definitely had diabetes, and she was using a faulty glucometer. And this member kept going to the ER because she wasn't able to control her blood sugar. And when we picked up the member, the nurse worked with that member to understand how to use the glucometer and how to, manage her blood sugars. And it became very apparent to the nurse that the glucometer that she was using was faulty and giving her wrong readings and thereby making her end up in the emergency room. So the nurse identified the issue, assisted the member in obtaining a new glucometer, and we therefore have avoided at least 1, if not more, ER visits, because this member would have ended up in the ER again for uncontrolled blood sugar with using that old glucometer. So 1 ER visit for this plan saved $3,036. So this is really what our program is. We work with the members, we get really good positive results with the members, and we get a lot of appreciation from the members that we're working with. And so here's a slide that communicates in their own words some of the thanks that our nurses get on a daily basis working with the members. Thank you.